Hello, and welcome to the CAP Today webinar for Thursday, April 24th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host, and I'll moderate a question and answer session after our formal presentations today. Today's webinar addresses a very hot topic in the field, as we all know, democratizing liquid biopsy-based precision oncology biomarkers in the United States. This is touches on critical things that are at the very edge of cancer care and patient care. So this very timely webinar, we're grateful to say, is made possible by a special educational grant from Thermo Fisher Scientific. We want to acknowledge Thermo Fisher for their sponsorship and thank them for their support in helping us bring you today's program. Today we have 4 speakers, and I'll introduce them all now in the order in which they will be speaking. Our first talk will be by Simon Heeke. He's a doctoral scientist at MD Anderson Cancer Center. He'll be talking about the current status of liquid biopsy oncology biomarker testing from a clinical perspective. Our second talk will be from Lauren Leiman, and she'll summarize recommendations for the equitable and widespread implementation of liquid biopsy for cancer care. Following Lauren, we'll hear from Charles Mathews. He's a partner at Clearview Healthcare Partners. He'll address the burning issue of liquid biopsy reimbursement changes in 2025. I know you'll all want to hang around for that. And finally, last but not least, and you want to stay tuned here, because Nikki Martin, who's with LUNGevity Foundation, will be speaking very importantly about the implications of liquid biopsy democratization for patients, perspectives from a patient advocate. And it's always great to hear from LUNGevity. I'm sure this will be a very good presentation to close the formal presentations, after which we will have Q&A. But before we begin, and I introduce Simon and invite him to begin his talk, I just want to give you a couple of housekeeping hints. First, use the Q&A pod that you see on your screen to pose questions, make your comments, and also if you have any technical issues, type them in there. We have live help available with both the website and the audio at any time in this Zoom session. And they're very, very good at helping you. Next, I want you all to know that we will post the full text and the slides on captodayonline.com in about a week after review. You should expect some follow-up from us and also from Thermo. And so I want to make sure you're aware of that. And finally, before I begin and invite Simon, I want to remind you that CAP Today, of course, does not endorse any products or services that may be mentioned today in today's webinar. And any remarks of mine are purely personal. They're not the policy of the CAP Today or the College of American Pathologists. And now it's my great pleasure to introduce Simon Heeke, and he's the head of Liquid Biopsy Translational Group. He's an assistant professor of thoracic head and neck oncology at MD Anderson Cancer Center, and I'm looking forward to hearing from him. So, Simon, please proceed.
Thank you so much. Thank you very much for the kind introduction, and it's a great pleasure to really start this webinar today with a short introduction about liquid biopsies and some, I think, novel aspects that we have to keep in mind when we think about liquid biopsies and democratizing liquid biopsies. As Bob has mentioned, just to resonate, that neither me nor Thermo Fisher will endorse or recommend any products here, just as a short disclaimer. Importantly, I think many people on this call today are a little bit aware about liquid biopsies, have heard it or have used it, but just to give a very little introduction about the concept of liquid biopsies, it is really about using body fluids to gain insights into disease processes, most commonly cancer processes or within cancer. And why we usually use like blood and urine when we speak about liquid biopsies, really every body fluid that we have can serve as a tool to use liquid biopsies, and I will showcase a little bit later some other body fluids that can really help to get more insights into cancer and into cancer biology. Importantly, when we speak about liquid biopsy, there are a lot of different components that we can look at. There are circulating tumor cells, circulating DNA, circulating RNA, exosomes, proteins. There are really a lot of different cancer-derived material that we can use, but all with the same idea of getting insights into the biological processes of the cancer using those liquid as a surrogate. I think what is very important when we speak about liquid biopsies these days is that liquid biopsies is not something of the future, something under development, despite having a lot of technological advances, but it's really something that is used and even FDA approved in some indications today. Importantly, when we speak about liquid biopsies and how all those cancer-derived material that we like to use and analyze is coming from, I think it is always important to remind everybody that there are two important processes why we can actually use liquid biopsies and get insight into cancer. Because generally, we can only use liquid biopsies because there's cancer-derived material released into the liquid, for example, in the bloodstream. And this can either happen by passive release because cancer cells are dying, thereby releasing all the content within the cancer cell into the bloodstream via necrosis, apoptosis, really releasing DNA there. But it can also happen via active release, for example, by the secretion of extracellular vesicles or other complexes, meaning that we really have to see the comprehensive analysis of cancer-derived material of encompassing those two different processes that we have there. Generally, we believe that DNA is coming a little bit more from passive release, while RNA seems to be a little bit more actively released. But I think it's really important that we consider this, as all those processes contributing to the amount of cancer-derived material that we see there. And with this, I already want to start to give you some more insights how we can actually use liquid biopsies, especially these days. Because importantly, for the rest of the talk, I will focus a little bit more on circulating nucleic acid, which is one of the materials that we use relatively frequently in the clinic, not because the others are less important, but really to focus here a little bit about novel aspects. Importantly, when we speak about circulating nucleic acids, like circulating tumor DNA, we can really retrieve all the information that we would retrieve from the primary cancer from liquid biopsy. We can use it to detect mutations, to see, copy number alterations, even look at epigenetic modifications, because, for example, DNA methylation is really, preserved in our circulating tumor DNA, or we can use it to even detect gene rearrangements. However, and what I think is really important to highlight is that in addition to DNA, we can also look at circulating tumor RNA and get additional insights, for example, by looking at gene expression, or again, looking at gene rearrangements. And gene rearrangement is something that I really would like to highlight, is something that is really interesting in the terms of liquid biopsies, because when we think about gene rearrangements, we really have two ways of thinking how we can detect them. When we usually detect gene rearrangements by DNA, then we know that we have, exonic and intronic regions that are building up, so to say, the rearranged gene, and that we are hoping to detect by finding, so to say, the overlap where the two genes are fused together. In contrast to this, we could also think about using, for example, RNA for fusion detection, because when we think that, in the RNA, all the intronic regions have been removed and we are only looking at the exonic regions that we have there, we might think that it might be easier to really find the position and the moment where those two genes are fused to build the new rearranged fusion gene that we have there. And this is a concept that we have already actually used quite nicely using tissue-based analysis. For example, using an integrated sequencer and a sequencing panel that is using both DNA and RNA, we were really able to detect gene fusions with very good sensitivity and specificity, highlighting that probably integrating both the DNA might be really a new way how we can improve detection rate of, for example, gene fusions. And this is something that we now really wanted to bring into liquid biopsies as well. And what we were doing is that we were looking at a cohort from the BrightStar clinical trial. It was including 33 patients with an ALK-positive non-small cell lung cancer. So having this ALK rearrangement, which is, found in approximately 4% of non-small cell lung cancer cases. And we were really looking at the detection of ALK fusion transcripts using DNA or using RNA. Interestingly, what you can see there, for example, at baseline, but also at other time points, that we found for some patients, we were detecting the ALK rearrangement only in DNA. For others, we were only finding it in RNA. And for many, we were finding it in both DNA and RNA. But this is really highlighting that, when we combine both of those, ways of detecting rearrangements, maybe we have a greater possibility of ensuring that we found those very important alterations, because for many, like for ALK, we have targeted treatments. However, it is not just the detection of, for example, gene rearrangement to administer the appropriate treatment, but also the detection of a rearrangement in the liquid biopsy itself seems to contain prognostic value. For example, what you can see there is that for patients where we detected an ALK rearrangement at baseline, that those patients had a significantly shorter progression-free survival than for patients where we could not detect the ALK rearrangement at baseline using liquid biopsies. And as you can see, we are also seeing differences if you look at RNA or if you look at DNA, really highlighting to us that those are two different ideas of looking at liquid biopsies that contain independently probably additional value that is really making it nice to combine them to enable prognostication and treatment selection. However, when we speak about liquid biopsy, I think it is very, very important that we can use liquid biopsy really across the whole treatment span. Because it's a relatively minimal invasive methodology, this is something that we can test longitudinal across, from the point of diagnosis to treatment monitoring the resistance to therapy, even through multiple lines of treatment, that we can really use liquid biopsy as a tool throughout the whole clinical treatment that we have there. However, the important and interesting thing is, like I was saying in the beginning, usually when we speak about liquid biopsies, that we usually think about liquid biopsies from blood. There are also liquid biopsy from urine, which is, relatively commonly used. I would also highlight when we think about democratizing liquid biopsy, expanding liquid biopsy, that we shouldn't limit ourselves to certain eluates, for example, only looking at DNA, because I was showing that RNA contains some information, but also thinking about how we can use other body fluids to really expand the access or the understanding of cancer. And I would like to showcase two studies that were recently published from my colleagues here at the MD Anderson, really thinking about how to differently look at liquid biopsies. The first one I think is really, really interesting, was looking at cerebrospinal fluid for really rapid molecular profiling from lung and breast cancer. And the authors in this publication were really thinking or looking how actually, CSF can be used to get insights into molecular profiling, how this is correlated to tissue-based profiling, and we're really able to demonstrate that even cerebrospinal fluid has a very good correlation to tumor tissue and might serve as an interesting novel way of using liquid biopsy. Additionally, in a second publication that was also published earlier this year, my colleagues were using FNA or FNA supernatants also as a way to really rapidly allow the molecular profiling from this novel idea of using liquid biopsies. And again, the same that we have seen, with blood and other body fluids, it seems like the FNA supernatant actually had a very good correlation to the cytology analysis, and therefore might really help or enable us to really get more insights into the molecular composition of the cancer. And this is, I think, very, very important, because we can think about liquid biopsies and multiple ideas, but we can also think about liquid biopsies to really expand access by reducing turnaround time. Because when we now think about a liquid biopsy versus a tissue biopsy, then we can see that when we have a tissue biopsy, there's always this, constant process that we like to turn around. How long does it take actually to get from a samples to a report and doing all, let's say, the next generation sequencing that we have there. But there's also a variable time frame, which is actually getting access to the tissue biopsy, which takes time to make an appointment. You need to get the patient into the hospital. You need to do it. And this really can be a relatively lengthy process. And even if we shrink down the constant process, you will always have, the variable time frame getting to the cancer sample. In contrast, when we now think about liquid biopsies, we also have this constant process of, library preparation, report generation, and everything. But when we now think that the variable time frame of actually getting the sample that we want to analyze into the clinic, we can now actually dramatically shrink the turnaround time. Because all we need to do is draw blood. We can directly move to the nucleic acid extraction, directly start, so to say, this constant process or sequencing that where we used to think about using liquid biopsy to do something that we used to do with tissue biopsy, we can also use liquid biopsy to think about doing stuff that we cannot do with tissue biopsy. And for example, expanding access to precision medicine and molecular profiling. And this is a very important aspect, because when we think about how we can actually bring precision medicine to the patient, we also have to think about the access to oncology care. And this is a very important paper for me that came out last year, which was really showcasing that within the United States, many parts within the country have no access to oncologists or no access to clinical trials to oncology. So how can we bring precision medicine to those places as well, democratizing precision oncology to really enable that more patients get access to precision medicine? And in this case, I think rethinking about liquid biopsy as a different way to get access to tumor-derived specimen that require relatively limited specialized sensors, minimal training, it can actually happen in the home of the patient. We can really think about using liquid biopsy to expand access to precision oncology and think about unique aspects of liquid biopsies compared to the commonly used tissue biopsies. What I'm showing here was not an idea to replace liquid biopsy and use liquid biopsies for everything, but I still hope I could show the liquid biopsy of a minimal invasive approach to really get real-time insights, that we can think about expanding the use of liquid biopsy by using additional eluates like circulating tumor RNA, or also using different biofluids that we have there to really get more insights, earlier access, and more expanded access to precision medicine, and really leveraging the unique abilities of liquid biopsies by rapid turnaround time and the easy sampling method. And with this, I would like to hand it over to Lauren Leiman for her talk.
Hi, good afternoon, everyone. How are you? I guess we're waiting. There we go. There are my slides. Hi, everyone. I'm Lauren Leiman. I am the Executive Director of BLOODPAC, the Blood Profiling Atlas in Cancer. I'm going to take the next 10 minutes to give you a brief overview of what BLOODPAC is, who we are, what we're doing broadly. And then I'm going to talk a little bit more about accessibility, both for the broad community domestically here in the US and also for underserved populations, and kind of discuss our recommendations, as it says, for equitable and widespread implementation of liquid biopsy in cancer care. And excited to take questions later after everyone's spoken, so please feel free to write stuff down. So this is just a regular disclaimer. Thank you so much for both CAP and Thermo Fisher for thinking of BLOODPAC and having us. This is the most recent picture of the BLOODPAC Consortium. We were formed 8 years ago as an initial commitment to the first White House Cancer Moonshot, with the idea that we could accelerate the development, the approval, and the accessibility of liquid biopsy technology for cancer patient benefit. If we were able to address kind of standardization for liquid biopsy, as well as aggregate data to support that standardization, and then also address kind of stakeholder engagement and through whether it's reimbursement and policy, global regulatory issues, and broadly a lot of the access issues that we see. Oops, excuse me. So our mission has remained the same over the past 8 years. Again, it is very refined. We really don't branch out at all from that. Though you see right in front of you our 3 goals, our 3 main buckets of the work that we do: our evidence generation, which is really the science side, our data portal, and that we really work on our data science, and our stakeholder engagement. Our mission has remained the same and steady over the years, and really excited that we have grown, though, in our membership to today, as of this week, over 73 members, forming kind of key collaborations across all of the industry. I think that when we formed BLOODPAC, we had this really realization that this is an incredibly difficult field. And we wanted to be able to walk hand in hand with everyone at one time up this mountain that we were trying to conquer. And so we do have members in academics, private payers, diagnostic developers, pharmaceutical companies, nonprofits who either fund in the space or advocate in the space, as well as several different government agencies that have worked with us, both domestically here in the US and abroad. I like this slide because it gives you a visualization of kind of who we are, what we're doing, who is involved in BLOODPAC, who contributes to the work that we do. And I think you can see it takes a lot to kind of align all of these different stakeholders. But over the past 8 years, we've been successful in doing so and excited about the work that we continue to bring to the field. These are our publications. I do believe that this presentation will be available to you later. If not, you are welcome at any point in time to visit our website and check them out. They are across all different areas in all the different working groups that we provide content to the community. So I encourage you to please anytime visit our website, or if you can click on these links when you visit if you're able to access the presentation. This kind of shows you the depth and breadth again of the work that we do across all of BLOODPAC. These again, and this is the last kind of broad slide that we have, BLOODPAC is different and interesting in that you are looking at 25% of the employees at BLOODPAC. We are very lean, and that the majority of our work is done by the experts in the field themselves, everyone on these calls. So when we have buckets, again, our evidence generation, our data, as well as our stakeholder engagement, each one of those has working groups underneath them. There are about 11 working groups, 10 to 11 at any point in time. You can see them on the screen here. And each of those working groups delivers a product to the community to be utilized across all those stakeholders that I put up on the slide earlier. We're going to talk mostly today about accessibility. Happy to answer questions about any of these areas. What's also wonderful about BLOODPAC, I think, is the ability to cross-pollinate within these groups and within these areas. There's currently work going on between the accessibility working group and the global regulatory working group, as well as between the accessibility working group and the policy and reimbursement working group. So our ability to kind of discuss what each group is focusing on, their deliverables, and then bring them together is really exciting as well. So now we're going to talk about accessibility, which I think is a key aspect that really needs to continue to be a large part of the dialogue that we have when we talk about liquid biopsy. There are 3 main takeaways that I want you to have from this presentation. The first one is that, yes, access remains a challenge in the field today, both broadly across our healthcare system and especially for underserved populations. The second takeaway I want you to think through is that liquid biopsy has the potential to really truly improve outcomes for patients. And on this flip side, it also has the ability to increase disparities and decrease access. And so I want us to think about making sure, and when we think through developing these products, distributing them, getting them out into the universe for patient use, how are we improving outcomes for patients, increasing accessibility, and not increasing disparities? And then I'm excited to say that I think that we developed a really good roadmap for action in our accessibility paper that has been available for roughly the past year. You're very lucky. You're going to hear from Nikki shortly, who is an author on that paper, Nikki Martin. And I think it's important to say all of the different kind of broad access issues are addressed in that, and hopefully that provides a guideline for everyone who's on this call. So first, our accessibility working group falls underneath kind of the blanket of our stakeholder engagement working group. The group is headed, as I mentioned, there are co-chairs and people who align the broader group. The co-chairs of the accessibility working group today are Rob DeManaway from Thermo Fisher Scientific and Bryce Portier from Loxo Oncology. There's a third member who's leading one of the projects of this working group, Phil Febo, who is leading a separate project that I'll talk about in a moment. The accessibility working group is here to wholly identify and address barriers to equitable access and clinical use of liquid biopsy tests. They are the last stop on the train, or hopefully the last stop, where we're helping. A lot of our work on the front end is helping to develop this technology to improve approval rates and streamline the process. This group really focuses on how do we get these tests to patients. About a year ago, we published a paper on recommendations for the equitable and widespread implementation of liquid biopsy for cancer care. And that serves, again, as a kind of roadmap for all of the work, the additional work and projects that we have within BLOODPAC. Right now, we are working on 2 different projects, which we're going to discuss briefly. This is the paper. I hope you can see it. I can also put it in the chat for anyone to access as well. There we go. That paper does discuss these 6 barriers in the landscape: introduction of new technology, performance uncertainty, social distance due to language or medical accessibility, fear of discrimination, financial concerns, and lack of awareness or education. All of those can kind of be generalized to the entire population, and then also some of them are more applicable to underserved populations. So we're going to skip over this. I feel we're running out of time here. I also want to talk briefly about our global regulatory working group and the interconnectivity between these 2 groups. Global regulatory group, where the accessibility paper was really focused on domestic issues and domestic challenges that we have, once again, broadly, as well as for underserved populations. Our global regulatory working group is focusing on not just regulatory issues, but reimbursement and policy issues as well across global stakeholders. That group is led by Jennifer Dickey from PGDX, LabCorp, and Elaine Katravanos from Tempus. They have formed, they're addressing, again, these kind of short-term, midterm, and long-term issues through the partnership, through an EU partnership that we've hosted with a number of our colleagues at Europa Bio, MedTech Europe, UCOPE, FPIA, and others. And the idea that we came up with most recently, about 8 months ago, was to create a presentation that takes the accessibility challenges we've identified and apply it to what happens if we are unable to assist in kind of helping to move the regulatory field forward in the EU. It can also be applied to other places, but this was specific to the EU. And what would the consequences be for accessibility for patients there? And so it's a good example of the interconnectivity and progress that we can make collectively faster with these 2 different groups. And with that, I think right on time, I want to thank our kind of leadership and the executive team. Our executive team really focuses on how we move forward as a consortium and as an organization as a whole. We also have a scientific co-chair committee that decides, are we addressing the right science? Are we addressing the right issues? And they're fantastic at doing that. And we have several different FDA and NCI colleagues who have been with us over many, many years, who have committed a lot of time and energy to our work, and we're extremely grateful to them. And finally, we also do have a number of projects with the Department of Defense, the Department of Veterans Affairs, and several others that we work on collectively in other areas. So thank you to everyone. And with that, I will turn it over to Charles Mathews.
Thanks, Lauren. Appreciate it. So what I'd like to do is I'd like to build on Simon did an excellent job highlighting some of the unique clinical applications which are enabled by ctDNA technology. And then Lauren was able to describe some of the importance of investing in evidence to support the value proposition of those applications, but also how crucial accessibility and access is as part of that. So what I'd like to do is zoom in on this kind of question of what is going on from a reimbursement perspective with liquid biopsy in the US. Just by way of introduction, I'm a partner at Clearview Healthcare Partners. It's a life science strategy consultancy focused on the bridge between novel technology and then moving into commercialization and access. So spend a lot of time thinking about coding coverage, payment pathways for novel diagnostic technologies and other technologies in the US and also globally. So just put together a few slides here just to kind of give you a quick overview and highlight some of the key trends and developments in this space. And these are my disclaimers. Thank you for the opportunity to come meet with this group and share some thoughts about what's going on in this field and hopefully contribute to the dialogue on this really important topic of resolving reimbursement for innovative technologies like liquid biopsy. So as Simon alluded to, I just want to highlight I view ctDNA as an enabling technology. It could be used in a range of different applications, some very exciting new use cases like early cancer detection, but also minimal residual disease. There's a lot of interest and investment in that. For today's discussion, I'm going to focus on what I would view as like the leading kind of clinical application in the oncology space, which is this comprehensive genomic profiling or kind of use of ctDNA to look at a panel of genes associated with therapy in oncology. So really enabling treatment detection. So then the question is that use case is emerging, and you can now have the technology exists to look at a broad range of biomarkers in a single blood sample. What are the payers willing to support, and are there mechanisms or labs that perform these tests to be properly reimbursed for the services they're performing? So to break it down, I'd love to give you just a quick overview of the key components of reimbursement. And I didn't create these categories. Actually, the Center for Medicare and Medicaid Services really has 3 different groups where each of those groups are looking at these issues independently. But coverage, coding, and payment are the 3 legs of the stool that kind of create reimbursement for diagnostic technologies. And I would argue it's much more of an ecosystem than any one single thing. So to get successful reimbursement and routine optimal payment, you need these parts of the puzzle to be pulled together in a way that works in a sustainable way, so that there's payment available when you need it, and it's at a good enough rate to justify the investment in the technology and the execution of the services. So amongst the 3, I would say the one we very often start with is focusing on coverage policy, and that's the delineation of things that are medically necessary versus investigational experimental. That's very much tied to evidence, and you'll see that reflected in payer coverage policies, where they will review the evidence and say, it's useful for this application, but it's really not proven for these other applications. But even if you have a positive coverage policy that says that, like we are now endorsing liquid biopsy, there's going to be questions about, well, how does a provider communicate to a payer and establish adequate reimbursement for it? And there's where something like CPT coding might come into play, so current procedural terminology coding. And that's the mechanism basically by which providers describe a service to a payer, and that payer then is able to understand coverage and say, if we cover that code, we don't cover that code. And then also that's linked to payment, and payment would be a value associated with that code. So I've seen situations in which you're able to get a code and a payment rate, but maybe don't have a coverage policy, or maybe there's a positive coverage policy, but you haven't worked through your way through the relatively arcane constructs of the CPT editorial panel to secure a novel code. Fortunately, in the case of liquid biopsy, we've seen progress in all these areas, and I'll highlight them now. So when thinking about coverage, one of the first places to start is think about payer mix. And in case of oncology care, we have primarily 2 payers types that are responsible for a lot of the coverage of people with cancer. One is Medicare, which serves the over 65 population. And Medicare has 2 pathways. It has national coverage determinations and local coverage determinations. So the system can be orchestrated by a single entity in Baltimore that reviews things and said, for the nation, this is what we're doing. But then also for things where the national group is silent, it ends up being a local decision by what are called Medicare administrative contractors. So back in 2018, there was a seminal pivot that occurred in this space where historically it was very much left to local coverage determination, but groups that pursued regulatory approval approached and received what's called parallel review. So they said, we're going to get this approved, and we're going to get a coverage policy at the same time. And this next generation sequencing policy was created. Somewhat interesting in its design, and it's really focused on the tool rather than its clinical applications. But if you read the policy, it very much centers around this idea of like looking at a panel of markers for it. And it was a pivot from this debate that's occurred in this space for a very long period of time between, well, should we incentivize labs with maybe a stick approach where you would say, hey, the FDA is going to regulate LDTs, you'd be using FDA approved products, or maybe more of a carrot approach. And this is a good example of a carrot approach of saying, if you use FDA approved products, there will be payment for it, which was a big shift in the thinking there. And so basically the language of the policy says for things that are IVD or LDT PMA that have gone through a clearance, Medicare will pay for them. Now, there's some conditions around when they will pay for them, like it has to be recurrent, relapsed, or refractory metastatic disease, so not paying for stage 1 or 2 patients. And also, you can't be doing multiple tests over a period of time. What's interesting is the design of this policy really centered around tissue-based testing initially, but as Foundation Medicine and Garden have gotten approval for their liquid biopsy offerings. They've been able to leverage this policy as well. So it was a big change in the industry to now say, like, Medicare is going to pay for these sequencing-based offerings. But as you might know, well, then what happens to all the LDT versions, the non-FDA approved versions? And that now still defaults down to the local level. And there's an entity called MolDX that kind of has stitched together a lot of the Medicare administrative contractors and has developed a number of interesting policies in this area. I will highlight two of them. One is this policy for plasma genomic profiling that kind of highlights a use case for it. And this has been one of the challenges of liquid biopsy reimbursement. That policy says there are situations in which liquid biopsy is valuable, but it really highlights that tissue biopsy is infeasible. So for people that can't get the tissue, maybe liquid biopsy is a solution, or a tissue-based CGP is negative. So you've done the tissue and you don't find anything. Maybe as a belt and suspenders approach, now you use a liquid-based approach. And then similarly, there's a policy around the use of Inivata's Envision First offering, and that also highlights this infeasibility thing and saying, well, it's only useful if you haven't already done the key biomarkers, the EGFR, ALK, and you want to use a tool to kind of assess that. So I think although it's helpful to have some policy here that guides you to where liquid biopsy could be valuable, I think many would look at this and say, this doesn't match the promise that Simon was highlighted earlier when he was talking about liquid biopsy as a tool could expand access to testing and make it more widely available. This is much more in the vein of break in case of emergency. Like you can't use tissue, so now liquid is your backup, which I don't think fully captures the value proposition of liquid-based solutions. And in a similar vein, commercial payers have kind of taken a somewhat similar approach here. I profile a number of the key commercial plans, and you'll see they do. This has changed remarkably since maybe even 5 years ago, where you can see they do definitely have positive coverage policies. But you'll see that many of them talk about it in the context of it is covered if tissue biopsy is unavailable. So we're thinking about tissue is the base approach, and then tissue biopsy is the backup. So you'll see in prior years, this version was all red. Now it's at least blue, but it's always on this exceptional basis. The exceptions to that are interesting advances where United Healthcare, which is one of the top 5 plans in the United States in terms of commercially covered lives, has now created a policy that says, but it's much more focused on the size of the panel. So if your panel is less than 50 genes, then we will go ahead and pay for it. We don't want to pay for whole transcriptome or whole genome or 300 gene panels, but if it's less than 50 genes and you feel like it's a valuable thing, go for it. And it basically puts liquid on par with tumor tissue and saying you could do either liquid or tumor. You don't need to worry. Then also, Humana did a very interesting policy where they said, we're going to aim for parity. Humana has both a Medicare Advantage business, which is like the commercial version of Medicare insurance, and then also their commercially insured lives. And they've said, we're going to look at these two things and say, let's match them so we don't have coverage inequities between our Medicare beneficiaries and our non-Medicare beneficiaries. And they do things like looking at FDA approval status and their listings in the Diagnostic Exchange Registry. So again, progress here, in particular, looking at like United Healthcare, Humana's potential bellwethers of where things may head. But right now, still in this kind of limited use case around tissue biopsy being unavailable. So that was on the coverage side. Let me transition over quickly to the coding and payment side. So here you'll see basically 3 categories of codes. So there's a code set up that we would call GSP, so genomic sequencing procedures. And there's a series of codes that created there to describe panels of various sizes, 5 to 50 genes, 51 genes. More recently, there was creations of codes that describe the incorporation of microsatellite instability or tumor mutational burden as part of additional offerings with different values associated with that. And then there's also what's called PLA codes, proprietary laboratory analytics. This is something, an extension of the PAMA Act, which created ADLT as a category, and people while trying to use that wanted to get novel coding specific to their individual technology. So you'll see that Garden, Foundation, and even Resolution have their own codes and payment rates associated with those particular offerings. But for the context of this talk, probably the most interesting one is this grouping at the bottom here, which is a series of novel liquid biopsy codes were created. And they borrowed that same structure we saw above, which is like there's a base analysis. So when the GSP codes first arrived, it actually didn't say tissue or liquid. In theory, you could use the same code for both of them. But now what we have is a separate group that says, okay, these are the codes you should use if it's cell-free nucleic acid analysis of these things. But they have that structure where it's like looking at a range of variants, but then if you add in microsatellite instability, there's a different value. If you add in tumor mutation burden, it actually doubles the value. So I think there's an interesting kind of question of like, is 2MB really that valuable in a clinical context? And does it represent a doubling of what should be the reimbursement? There's a relatively convoluted pathway we got to this, but this is kind of a reflection of where we're at. And it doesn't seem to match the language of the coverage policies, which are more focused on infeasibility. So there's an open question of like, well, if you go ahead and use this code with tumor mutational burden, can we clinically justify that? Is there evidence that supports that then will justify the use of this code at this price point? So the last point I wanted to make was just thinking about the evolution of the space. I think one of the key challenges here, and Lauren did a nice job of highlighting this in her talk, is that there's further evidence needed to just find the clinical utility of ctDNA approaches. You heard me highlight the key limitation right now is it's basically breaking case of emergency when tissue is infeasible. And I love it as an industry if we did more to kind of emphasize the utility of either doing liquid versions in parallel, or here's times when you could do both, but liquid actually provides a lot of unique independent value because it's a different methodology. In a similar vein, there's a lot of argument and debate going on right now with LDT, what's going on with regulation of that and quality control. And I think that ties into some of the efforts of BLOODPAC, but also ties into some of the efforts of others in this industry trying to look at what's the right way to regulate liquid biopsy and develop evidence that shows that it's very useful for particular clinical applications and is just as accurate or maybe even more accurate in certain use cases than tissue technology. There's an ongoing debate around payment reform. I mentioned the codes and payment rates that have been signed and mentioned PAMA as the legislation that's shaping that, but there's those that are working on something called SALSA, which is another bill which may reform those payment rates and cause a re-examination of the valuation of liquid biopsy technologies. But at the core of all of this is this kind of increasing interest in the technological innovations. I get stuck in different conversations particularly with pharma players where they're like, well, ctDNA is good at this. And I'll say, well, we don't know the full limits of what ctDNA can do. And I mentioned before, it could be MRD, it could be ECD, it could be more work on the panel side. A lot of the focus historically there has been on the DNA side and versus the RNA side. So is there an opportunity to kind of shape a reimbursement narrative with the addition of both broader depth and more breadth in terms of the use cases for ctDNA technology? But hopefully this gives you a bit of a snapshot as to where we're at. And I welcome questions from the rest of the group once we have a chance to get to Q&A. But thank you very much for the opportunity to share this with you today. And at this point, I'm going to hand off to Nikki, who's going to give us an overview of some of the things that LUNGevity is working on.
Wonderful. Thank you so much. And thank you to CAP today and to Thermo Fisher for inviting me and LUNGevity to participate in this. My name is Nikki Martin. I am the LUNGevity Foundation Senior Director of Precision Medicine Initiatives. I'm going to be sharing with you more about the patient experience with liquid biopsy in the context of what you've already heard about, access and, comprehension really by the patient about what this type of test is, what it does for them, and how it connects them to treatments or clinical trials. LUNGevity is a patient advocacy organization. We focus on lung cancer. So in these slides, I'll be really presenting it from the lung cancer point of view. But I think that a lot of the feedback I'll be sharing is relevant across the spectrum of any cancer type. And because lung cancer is farther ahead in terms of precision medicine and maybe access issues with liquid biopsy, the lung cancer patient insights are really important for understanding how we can shape the market so that it can support other cancer types, other cancer patients when liquid biopsy is, further adopted across the board for those patients. So first, I'm going to start talking about biomarker testing, and then I'm going to get into liquid biopsy. I just want to set the stage When we're talking about biomarker testing for patients, like identifying the biomarkers so that patients can get the right treatment, put on the right care plan for them, they have three basic questions that typically come up. What is a biomarker? Why are they important for me now that I have cancer? And can I pass these biomarkers to my patient, to my children? These are typically the three most important things that patients are thinking about. And in general, the average patient does not know the answers to these, and they need their doctor to talk to them about these topics. And as with all aspects of cancer care, a patient doesn't want to be a bystander. So they don't want to have things done to them. They want to be part of the team that's drawing up the solution. So here are some additional points to make about what they're looking for. They want to understand the expectations of treatment, what is expected of them as part of this diagnostic process. They want to be included as part of the care team. They want to know that the care team has their best interests in mind, that they're going to have access to the optimal care for their type of cancer. And they want to have this knowledge and powers as part of their diagnostic process and treatment decision-making process. So I think that's important to set the stage with that very basic information, but sometimes overlooked. And then the next thing is some of the speakers have already touched on this, but we still face a lot of barriers with patient access to biomarker testing, whether it's with a tissue or a liquid-based test. And these barriers are much more accentuated for people of color, lower socioeconomic level, lower health literacy level, English as a second language. Immigrants have no insurance coverage or low insurance coverage. And then if they're meeting with a doctor who has low understanding of what the guidelines recommend, or just isn't familiar with the latest offerings on the diagnostic side. So let's talk now about liquid biopsy. In preparing for this talk, I spoke to several patients that are in the LUNGevity network, and I found that there was a range of information that they knew about liquid biopsy. Some of them had a very literal perspective of liquid biopsy because the term, as you know, it's a very jargon-based term. It doesn't have any meaning if you're just approaching it literally. And so you can see that first quote really reflects that. Some people might have had a little more information, but there was a lot of confusion about what exactly it means. They knew that it had to do with the blood. That was it. And then there was also, the more savvy patient who does have a strong understanding and has a good sense of the key benefits that we all think about, the practical benefits of liquid biopsy. So doctors and people in the labs need to keep this in mind, I think, because it relates to not only how doctors should be talking to their patients, but also maybe how laboratories are creating like their results report from the liquid biopsy. I think having some basic patient information at the top of the results report to explain what this type of test is, that it was used with your blood and what it does, I think is critical to help eliminate some of this basic confusion that patients have. So there's a general awareness, understanding, there's a general level of perceived benefits for some patients, but then even patients with the most savvy level of knowledge have concerns about not only the perceived limitations of liquid biopsy, but also how does this really relate? Can I trust this for making a treatment decision? So I'll just share a little bit about that. As I already mentioned, there is a wide understanding of liquid biopsy by patients. There's confusion about what liquid biopsy is and how it differs from other types of tests. There was a lot of confusion around MRD testing, which surprised me that patients were even familiar with MRD testing. But those that have been diagnosed a while ago, they thought liquid biopsy was only MRD testing, and that it didn't have anything to do with treatment selection. So I think that just has to do with whether they're getting how they're learning about it from their doctors. But it again just brings us back to they don't know what MRD is, but they're hearing it in the context of liquid biopsy. So that's how they're perceiving it. They didn't understand that it might have a relationship to treatment selection. So the terminology becomes really critical, that we get alignment on that, and that it becomes much clearer for the patient. So on the perceived benefits, they were unclear. Well, they were clear on the fact that it was less invasive than a tissue biopsy, of course. They understood that it had faster turnaround time, and that would, for them, mean that they could start their treatments faster. And they were also really curious about liquid biopsy as a screening tool. And I think someone mentioned that would be miraculous if that was possible. So, there is excitement about this type of technology. But again, there's a lack of understanding about what all it can do. Well, let's talk about some of the concerns that they had. There was a lot of discussion around what if it misses a biomarker, and what does that mean for me maybe not getting on the right treatment? Some of the more savvy patients actually had compared their tissue-based tests with their blood-based tests, and they could see that there were some biomarkers that were found on one test and not the other test. And to them, that was very concerning, as you can imagine. They don't understand what the biomarkers are for, or even if they have a role. Maybe they're just a variant of unknown significance. But to them, again, those tests should be equal in terms of their results. So there was also concern around the timing of the test. What if my doctor gets my results back for liquid biopsy before my tissue results, and then they make an incorrect decision to put me on an immunotherapy when I may not have a biomarker? So they have a basic level of understanding of some of this, especially from talking to other patients in the space. And they're concerned that maybe as the technology advances, my doctor, will he or she know how to take advantage of this technology for the best results for my care without making a mistake. So here again, words, the technology that it's developed in labs. So it's understanding that the technology liquid biopsy is a jargon-based term that has proliferated, but unfortunately patients, and I think maybe even providers, end up having to navigate the difficult terms that are all generated by companies and by professionals themselves. And I think it would be really beneficial for the industry, with advocacy groups and providers, to align on how are we going to talk about this, not only to discuss different types of tests as they get developed, but also most importantly with patients, so they're clear on what does what. And finally, these are in my opinion, these are the key ways we can start to overcome some of these barriers that patients have to access the test and understand the benefits. HCPs need much more education. We need better policy and support advocacy so that there's coverage for both tests at the same time, tissue and blood. And finally, much more improvement in how patients receive communication about the tests from companies, from their pathologists and the laboratory reports with the results, and from their oncologists and nurses. I encourage you, if you're a doctor or nurse listening to this, to take a screenshot of this QR code. This is a tool that we created with, it's a pan-cancer tool. It looks maybe a little busy, but it's a tool that guides a patient to know how they can talk to their doctor to find out if they've had liquid biopsy, if they've had tissue testing, and what the results mean for their care. We developed this with many other advocacy organizations, patients, and providers, and have heard much positive feedback on it. And yeah, so in summary, I encourage everyone on this call to think as much as possible when it comes to liquid biopsy. How are we educating and engaging our patients about it? Are we using patient-friendly language? Are we including them in the decision-making process for how to use this tool and how to use the results? Can we explain to them how the results impact their treatment decisions and make sure that's really clear? And also, if we're using it for monitoring as well as treatment selection, be really clear on what the difference is. So with that, I will close, and thank you again for this opportunity.
Nikki Martin, thanks to you, and thanks to all of our panelists. Let me remind the panelists now to turn their cameras back on live, and also go ahead and turn your microphones on. And I'll mention to the audience once again, you'll see the Q&A pod on your screen, and you can make some comments there if you wish. You can ask some questions. I do want to let you know and let the panelists know we plan to run 5 to 10 minutes over past the top of the hour, although we'll be understanding if anyone has a tight schedule and needs to leave. But otherwise, I'm going to launch right into this. And my first question, of course, is to Simon Heeke. As always, when we get into these type topics, we get questions about the comparison between digital PCR and NGS. And I think you're an ideal person to address that question for me. So go ahead, Simon.
Thank you so much. I think that's a question that deserves its own webinar. And of course, there are a lot of technical complexities. And, we could only cover a couple of things here, not even speaking about, what Nikki mentioned, MRD, early detection. I think generally, it's important to highlight that, digital PCR, I think, is a fantastic method. It is highly sensitive, not only for mutations, but only for copy numbers. And I think the selection of the right test needs to be considered in the right context of the cancer. For example, when I take lung cancer, for example, as an, where we have a lot of those targetable alterations, relatively complex one. We have, more frequent one like KRAS or EGFR mutations. We have, some more rare alterations like NTRK fusions, for example. There has been research that demonstrated actually that NGS is at the end more cost effective because at baseline, when you see a patient, you don't necessarily know what is the mutation. So in these cases where you have a very complex situation, it seems that NGS is more cost effective than a sequential approach. This is why I was, for example, highlighting NGS, especially because when I stick with the example of lung cancer, there are sometimes mutations, for example, EGFR exon 20 mutations that are not necessarily covered by a digital PCR, but would be detected by NGS. That usually, and I say this outside, of Charles' discussion about reimbursement and everything, strictly speaking about the data here, that it seems to be, more appropriate to use an NGS assay in this context. Of course, there are many other cancer types with a less complex, genomic landscape where digital PCR is an absolutely great tool to use. And I would argue it's not just digital PCR, even qPCR is still a tool which, can be relatively sensitive, is very good, cost effective. And especially, outside of the mutation detection, I would also highlight the methods for example, treatment monitoring. Like when you know what the gene is, for example, your patient has an EGFR L858R mutation, for example, then digital PCR is an excellent, cost-effective, short turnaround method that can really highly sensitively allow the tracking of mutations. And for example, this has been used in the Mariposa trial and the FLORA2 trial to track EGFR mutations within a clinical trial. So it's not that NGS is the answer to everything, but I still think it's important to really consider the requirement for each case specifically. And of course, for the technical things, we can have a long this discussion about all the different aspects.
Simon, thank you very much. We'll be back to you in a moment with some other clinical questions. Lauren let me know that she's on a tight schedule today, so I want to get a question to her. I know you've got a lot of experience in this field, and my question is, and I will ask Nikki to weigh in on this as well, are things improving or are things getting worse in terms of access, in terms of patients getting all the proper biomarkers that their condition warrants? This has been a big topic at recent ASCO meetings and other meetings. Let's hear from Lauren, and then I'll ask Nikki the same question.
I think from my perspective, I'll back up. I think, and I know this is oversimplifying everything that everyone here has said, but strangely enough, we had to write this, and actually the stat op-ed that came after our article that came out, people were very confused actually about what liquid biopsy is and does. And so I'll just break it down into like 3 different buckets, right? That are much oversimplified. Liquid biopsy for treatment, liquid biopsy for looking at, for residual disease and monitoring, and then liquid biopsy for screening and multi-cancer early detection. 3 very broad buckets. There's a lot that goes into that, but that's for patients especially, and your GP, that's a really a good, easy buckets to fill them in. I think in the treatment space, access is increasing. These tests are being approved. Some of them are being reimbursed. And I think there's a really nice trajectory there. I think coming soon over the next several years, MRD tests will make a lot of progress as well. I think what will be interesting is to see how the early detection space evolves. And to me, that is the space that will really have a large impact on potentially the decreasing disparities. So when we talk about, I think there will always be a population of people who will be able to pay for these tests, for early detection tests, as they become available into the future. But I think it has the potential to really increase the space between the haves and the have-nots, especially in healthcare. And so they also have the potential to really decrease that space. And I think there's a lot of planning that needs to go into it. So on one hand, we're spending a lot of time developing these tests and making them better. But I think there's a whole massive conversation around how do we deploy them appropriately? From who's going to run the follow-up tests if you have a positive result, to reimbursement, to how do you utilize them to really reach populations that haven't been aren't receiving equal access right now. I hope that answered your question.
Yes, thank you very much. And Nikki Martin, I know you have been around this topic for a long time. What's your reaction to this similar question about access and really coverage of the patients who need biomarker testing and often, as studies show, are not getting it?
Mm-hmm. Yeah, I think access is improving. I think testing companies are still footing the bill, making sure that patients don't get a bill if it's not reimbursed, which is not feasible, especially if the testing is performed in-house. But I think access is improving, but it's not improving fast enough, and there's still a lot of patients in rural areas, as that chart displayed, where providers are not ordering either type of test. Small sites. Yeah. So
thank you. Charles, as I knew we were going to have quite a few questions for you. I'm going to lead off with the following. Could you please speak to CPT codes such as 81479 that are not specific to a technology or a biomarker, and the use of those codes in the case of liquid biopsy?
Yeah, it's a great question because if you look at this space, it's really evolved in terms of the variety and availability of different CPT code options. Just simply put, we have a mixture of analyte-specific codes, so things like KRAS, EGFR have specific things. We have methodological codes, which in the case of liquid biopsy, I mentioned the GSP codes, the genomic sequencing procedures. And then proprietary laboratory analytic codes specific to individual technologies. What I've guided clients towards historically is to say, look at the available code options. If there's one that you feel appropriately describes the technology and has the adequate value associated with it, then it's best to leverage an existing coding option. But with the recognition that we're innovating here and there's novel approaches like MRD. When it first arrived, there was no code for MRD. So very often people are drawn to something like 81479, the miscellaneous code. I think the challenge with that is it involves manual review and adjudication. So basically someone at each plan is reviewing that claim and making a determination on a case-by-case basis of, is this something that's necessary? And what can happen is 1 week you can get a lot of reimbursement, and the next week all of a sudden you get none, because that person went on vacation and a new person is looking at the same data package and drawing very different conclusions. So it's an important part of the puzzle. It's an important bridging strategy. It's particularly if you perceive there to be a novel technology or novel use case associated with it. It's a great initial offering, but I'm always aiming towards how can we get to something more sustainable? How can we get to something more routine? I think both Nikki and Lauren highlighted like that access is a challenge here. And part of that is just making it so it's routine, optimal payment on a go-forward basis. So we're not having to fight a fight every time. So 81479 definitely helps kind of put that value message right in front of payers. But I always view it as kind of a relatively short-term solution.
Thank you. Thank you very much. Good answer. And always I recommend that labs and providers counsel with their representatives when they're within their institutions and their billing managers, et cetera, because this is getting to be everywhere a very complicated question. So Simon, I promised you some more clinical questions, and they're coming quickly here. So if you could be very brief, I'd be grateful. Tell me, what is the current state of liquid biopsy for detection of recurrent HER2 positive breast cancer?
Well, that's a question with the comment on being very brief. It will be very challenging because by the time there's so much research, by the time I stopped answering the question, probably there's already new data. Yes. I think generally there's a lot of research going on, using circulating tumor cells, using DNA methylation, using, many other tools. It seems like there are some promising solutions. However, on the sake of being brief, it seems like we still need a little bit more research to really clarify which tool at which time point will really be helpful in defining this. But again, this is for the sake of time. I could probably spend 2 hours speaking about this.
I understand. And I won't give you 2 hours, but I'll give you another question right now, which is, if a genetic test for Lynch syndrome is positive, would it be more relevant to have a liquid biopsy test to monitor early detection of colon or endometrial cancer?
I think this is, again, for the sake of being brief, I think this is a very, very interesting questioning, opening the whole topics around cancer screening. I think it's a very, very interesting idea. To the best of my knowledge, there are no studies actually who have ever looked at this, if, so to say, this might improve. So I would be careful at that time, giving the data that we have around the topic. But of course, seeing how liquid biopsy-based screening compared to, other modalities is something that is, again, under so much active research, and I think we have to be very open about it. But it seems like a field where the amount of data is still evolving, that I would be careful at that time to recommend, switching anything over, because we really need not only trials, but we need well-designed trials that really demonstrate that this is a method that shows, superiority. If I may add this, especially because we know that those screening tests might lead to some false positives. And there has been, a lot of studies showing that, those false positive results might sometimes need months to be resolved, that there's not a cancer. So especially in the context of this, I would really, await more clinical studies before, using this as a recommendation, unfortunately.
Thank you. Thank you
And
very
Bob,
much.
if you don't mind, I'd just like to layer on to Simon's point,
Please
because
do.
I think it's a really interesting point. We've highlighted that there's some different use cases for liquid biopsy technology. Liquid biopsy lends itself particularly well to screening, right? Like the idea of it's much easier to get a blood draw than it is to like serially biopsy people with indeterminate nodules, those kind of things. So the challenge that we've run into from a payer perspective, when I've talked to payers about it, they say, geez, it's just really mind-boggling them, the idea of screening otherwise healthy 20 and 30-year-olds for a very low yield in terms of who actually has cancer. So I love that GRAIL exists. I love that GRAIL is working on this. I love that GRAIL is out promoting this as a concept. And I do believe in our lifetimes we will live in a world where you do have kind of serial screening going on. But the idea of enhancing that pool or changing the risk characterizations of that pool as maybe the initial use case for screening, which could not just be Lynch syndrome, but take like women that are gBRCA positive, like we know that there's correlated with breast cancer risk. That could change the equation on the yield of testing and what you might be able to find and make that a little bit more tolerable for payers. It could potentially open that up as a pathway. So I'm intrigued by looking at that link between genetics and the appropriate patient population, not to the aim of like forever just limiting it to people with that background, but just saying that could be a easier proof point that then we could build on to get to a world with ubiquitous early cancer detection screening.
Thank you. Excellent answer, I would say. If you can tell me quickly, you've had a lot of experience in this field to see how reimbursement evolves around new technologies. What is the time frame and scale of reimbursement for liquid biopsy like today compared to other technologies that have been introduced, matured, and gained a reimbursement? I'm sure everyone would like to get your opinion about that.
Yeah, and this I think relates to the diversity of use cases that Nikki highlighted. Is I could say they're each on a spectrum. The one that we are living in a world today where we have access to liquid biopsy. Now I mentioned before it's somewhat limited and it's like often in cases where tissue is infeasible, but I would say that is in progress and with additional evidence showing not only the accuracy but the clinical utility of use of liquid biopsy either in parallel or as a substitute for technology for the therapy selection use case, I think that could happen even just in the next couple of years. Then probably the next feasible one would be MRD because there's some both government sponsored trials, but also a lot of pharma sponsored trials that are showing the utility of MRD in different use cases. I'm thinking about colorectal and the Signatera offering as an example. So I think MRD is going to come online quickly and has a strong value proposition from a payer perspective because it shows like people don't need adjuvant therapy or do need adjuvant therapy as a use case. The one that I think is the most complicated and probably will take the longest is early cancer detection, just because it's just so disruptive in terms of, and Simon correctly highlighted the false positive piece. It's a question of like, we don't even know what evidence to produce to show it is valuable. It has right now it's being used almost in a consumer vein where it's like if people want to pay for it or there's government or employer sponsored programs where they're paying for it. That may be that's where it sits before it eventually transitions to the payer audience. But I continue to be optimistic because I believe in the power of ctDNA technologies. I believe that they will be very helpful in a range of use cases. And the operational mechanics of getting a code and developing evidence that shows that value, that just takes time, resource and effort. But I think if we band together as an industry and focus on this and we're believers in the technology, we can do a better job of articulating that value proposition and landing in a really good place.
Thank you, Charles. And with that, I'm going to give you the last word, and I will begin to wrap up here. This has really been an extraordinarily good session, very rich, and I'm grateful to all of our panelists, Simon Hieke, Lauren Leiman, and Nikki Martin, and of course, Charles Mathews, who you just heard from. I also want to thank Thermo Fisher. They are been bringing us lots of enlightening sessions on the CAP Today webinars. We're very grateful to them. We can't do this without them. And finally, I want to thank all of you in the audience. I know very well time is of the essence in laboratories. There's plenty of shortages all around from top to bottom. And so for you to take time out to join us is particularly gratifying, and I want to thank you and acknowledge you. So with that, thanks to all of our panelists, thanks to Thermo, thanks to all the participants. And now I'll bring the webinar to a close.